so deeply with us. By coming together to review, understand, and learn about past tragedies, we take crucial steps toward preventing future losses and ultimately saving lives. The National Domestic Violence Fatality Review Initiative is a vital effort uniting a diverse perspective and disciplines to confront the complex dynamics of domestic violence. Your commitment to reviewing domestic violence-related fatalities, identifying systemic gaps, proposing solutions is invaluable to our collective mission and ensuring that no life is lost to preventable violence. The impact of this conference will be felt far beyond these few days. By sharing your knowledge, experience, and insights, you're helping to build a safer, more informed society. You're empowering professionals across the country and the world to address domestic violence more effectively with the tools and understanding needed to create a meaningful change. I want to express my gratitude to the Arizona State University Family Violence Center, to Chief Gerald Monahan, the Yavapai College Justice Institute, all of those involved in making this happen, and each of you for your tireless work that you do, not just here at this conference, but every day in your respective fields. Your dedication to improving responses to domestic violence, protecting victims, and holding systems accountable is both inspiring and essential. So thank you again for being here, for your passion, and for your unwavering commitment to this cause. Welcome to Yavapai College, and welcome to a conference that will surely spark action, inspire hope, and lives. Thank you.
Thank you so much, Dr. Ryan, for not only being here today, but for so graciously allowing us to use your campus here for this conference. Once again, my name is Susan Carbon, and I am so pleased to welcome all of you here to this conference and all of you who are streaming in from around the world. We have participants here from over half of the states and territories and from several countries, including a large contingent from El Salvador. Me gustaría darles a nuestros invitados de El Salvador una bienvenida muy especial. Estamos encantados de tenerlos aquí y esperamos disfruten la conferencia mucho. So, my apologies for the poor pronunciation, but know that it comes from the heart. So, this conference has been a long time in the making. COVID put a major pause on fatality review work and engagements like this. There's a huge pent-up desire to reactivate and re-energize, and this conference promises all that. I've been a judge for nearly 35 years. During that time, I have focused my career on domestic violence, and for many years chaired our own fatality review committee. I've had the good fortune of working with and training judges, law enforcement officers, advocates, prosecutors, and many others all over the country and abroad, particularly around areas where domestic violence intersects with family courts and when firearms are involved, particularly in the context of civil protection orders. I also served as president of the National Council of Juvenile and Family Court Judges and chaired a committee that created a multidisciplinary guide to the issuance and enforcement of protection orders that I'm proud to say is used all over the country and has been adopted in many countries abroad as well. I also had the great privilege of serving in the Justice Department as the director of the Office on Violence Against Women during the Obama administration. And in that capacity, I had the occasion to work with administrations from around the world. I share all of this information because at its core, the common denominator of our best work was coordination and collaboration across systems and agencies, or as we call it, coordinated community response. All of you are here because you too have devoted your professional endeavors to addressing domestic violence. You know as well as I do that these cases are difficult, challenging, and at times sometimes what we do just isn't enough. So we keep trying.
Yeah.
What we do know is that when we work together across systems and agencies, between governmental and community organizations, we have the best opportunity to affect change. And that is why I am so excited to see this conference come to fruition. Because in my 35 years of work in the field of domestic violence, I see homicide reviews as one of the most instrumental and insightful tools that we have to examine how we as a society deal with domestic violence, and by studying homicides, what we can learn to then prevent them and make our communities safer. No matter where you are from or what your own model might look like, I think it's safe to say that we all share that same goal, making our communities safer. Over the next 2 days, we're going to have a golden opportunity to immerse ourselves into fatality review work. We have 5 plenary panels, 2 mock reviews, and 4 breakout sessions. We have truly incredible faculty from around the world, including some who will beam in. And then this evening, we will have an opportunity to socialize together. Except for the mock reviews, our plenary and breakout sessions will each be 90 minutes, 60 for the principal presentation and 30 for Q&A. We want to make certain that we can allow plenty of time to answer your questions. And inside your packets, you're going to see some little note cards. So for our plenary sessions, you can write your questions down, pass them to one of the faculty staff here who will take them, and we'll talk about that a little bit in more detail later. We are being recorded and live streamed, so we will need to strictly adhere to the timeframes in the agenda. Sort of like when you're up at the Supreme Court and the light at the podium goes red, it means your time is done, you're gone. So before my time runs out, let's get on with our program. You can imagine that in over 35 years, I've met hundreds of people, bright, inspirational, professionals and community leaders, but a handful of them really stand out. I will share that when I first met Dr. Webstale at the first ever Fatality Review Conference in Key West some 20 plus years ago, I learned what it meant to be a real visionary. Dr. Webstale was the first to look at domestic violence through its worst possible ending, a homicide, to examine through a whole new lens how we might prevent them. Dr. Webstale has been a game changer in the field of domestic violence. He challenges us to think creatively, he challenges our conventional wisdom, and he asks, how do we know what we know? And how can we learn what we don't know? Through his Fatality Review Initiative, he brings multidisciplinary teams together to study these painful cases. He was doing coordinated community work long before the field even had an acronym for it. Fatality Review is the quintessential CCR. Since getting his PhD in 1991, Dr. Webstale has undertaken extensive research, policy work, and teaching. He's authored 6 books. Just this year, he published a groundbreaking look at domestic violence and dementia entitled Fatal Family Violence and the Dementias, Gray Mist Killings. Among other responsibilities, he is the director of the Family Violence Center at Arizona State University and has received a host of significant awards, far too many to list this morning. Suffice it to say, but for Dr. Webstale, we would not be here. Please join me in welcoming Dr. Neil Webstale.
Good morning and welcome to beautiful Prescott. I get a little bit nervous when someone introduces me as a doctor. And when I first got my PhD at the University of London in 1991, my PhD supervisor, Eva Germanikov, said to me, to make this real, you need to put this title, doctor, on your British Airways frequent flyer card, or something else. And I've been in the United States for a while, and I said to her, well, maybe my Chuck E. Cheese's card. Anyway, that never happened. And I said to her, I really don't want to be confused with someone who might be useful in a crisis. I really mean that. But anyway, I digress. I have a few thanks to give out. First of all, thanks to Dr. Bryan and to Chief Monahan for opening up Yavapai College and the community of Prescott for always opening its arms to the work that we do. We greatly appreciate it. We've done a lot of work in this Yavapai County, this beautiful area. So thanks for that. I want to thank the Office on Violence Against Women for funding our work for so many years. They've been absolutely wonderful and supportive of us, and we're most grateful for that. And I wanted to just note this formally. This is the grant number from the Office on Violence Against Women. So we have that information. We also are funding this through 2 other grants. I'm grateful also to USAID for bringing probably around 30 of our friends from El Salvador who have come to work on this conference. USAID is funding a project that the Family Violence Center has in El Salvador. So a special welcome to our friends from El Salvador. We also thank the Governor's Office for Youth, Faith and Family in Arizona and the grant there that is funding contributions to one of these panels, the Community Informed Risk Assessment panel. As I say, it's funded with Stop TA dollars, but they originated in Washington, again, with the Office on Violence Against Women. So again, you have that data. I want to say that we have 400 people at least registered for this event. We have 300 in person, and we also have another 100 or so internationally. And I wanted to extend a special welcome to our international colleagues who we work with, people connected with the UN, who may be listening in, people in Australia, New Zealand, Canada, Western Europe, who are doing fatality review work. And we're, again, most grateful for them for turning up and supporting our event. I also want to welcome many people, many faces who I've known over the years doing great work within the US, fatality review teams all across the US. Fatality review took a major hit with COVID. The teams went underground, they worked remotely, and we're slowly resurrecting those teams out of the ashes of the COVID pandemic. So we're glad you're all here, and we hope that we'll do our best for you to have a really nice conference. I'm going to do the following things today in my brief time with you. I'm going to talk about really definitional issues: domestic violence fatality review, domestic homicide reviews, and femicide reviews, as the international language goes. I'm going to talk about some of the implications of those definitional issues. I'm going to talk about philosophy and the origins and spread of fatality review and what that might mean, team membership scope, process of reviewing cases, confidentiality and ethical issues, and also outcomes. And I will finish by reviewing I'll spend about 5 or 10 minutes reviewing the actual focus of the conference and specific plenary sessions. So let me start by simply defining what traditionally domestic violence fatality review is. It's just a way of identifying and analyzing those homicides, suicides, and other deaths, and sometimes near deaths, depending on statutes, that are caused by somehow related to domestic violence. So this typically follows, the statute, in the sense that if people are married, they're maybe cohabiting, maybe they're family members, teams review those cases. They can be formal, informal. There's a tremendous range in terms of the kind of cases that are reviewed and the ways they are reviewed. And we don't have a horse in this race. I mean, we just try to offer technical assistance to meet the needs of communities. The idea, though, is to develop preventive interventions, to be thoughtful and to think through ways that we can stop some of these killings. So prevention is at the heart of the work. And since I started this work with a large group of people, there were probably 50 of us who were involved in setting this initiative up. Judge Carbon is very generous, but we worked together, many of us, in those days. First of all, we note that there's tremendous variation across countries, and so there should be. There's tremendous statutory variation. And team preparation and preparation for these initiatives takes a very long time. And you can see here from the slides that the UK government took many years to prepare itself before it issued its 2011 guidance on how to initiate and operationalize domestic homicide reviews, as they're known in the UK. And this followed many years of deliberations. The British Home Office, with a number of influential individuals who were involved, some in tragedies. We have Frank Mullane here from England, who lost his sister and nephew in an intimate partner homicide, a double homicide, who was very instrumental in launching that in England. And we have a number of other individuals. If you look in Portugal, for example, they spent years, they hatched these ideas around 2009, but they actually launched in 2016, a 7-year period. It takes a while to think this through. We have Antonio Castano here, formerly of the Ministry of Justice in Portugal, who was instrumental in launching that. And Antonio will be talking on 2 of our panels to give us the benefit of his wisdom. And then internationally, particularly in Latin America, where violence against women is not only rampant, but is also accompanied by tremendous impunity, much greater impunity than we see, for example, in OECD, richer nations. Much greater impunity. So there we have seen, amongst other places, observatories. These are counting ways. And our friends in El Salvador are beginning to do that work and do it remarkably well. And we, of course, need aggregate data to know the scope, the magnitude of the problem. The UN Secretary General, we were at, a number of us here were at, and online as well, our friends online, were at the UN meetings in Vienna in November of last year, in 2023. There was a discussion, but basically the UN Secretary General recommended member states should strengthen multidisciplinary and coordinated crime prevention and criminal justice responses. And that includes discussion of setting up domestic violence review committees or femicide review committees. These are huge international issues now. This is not just something that we do in the United States. And as I will talk in a moment, the implications are profound. The political and historical significance of this, I think, is something to pay attention to. If you just look at the numbers, the raw numbers, and these are taken from recent reports through the UN, nearly 89,000 women and girls were killed intentionally across the globe, across 2022. It was the highest number that was recorded in the last 2 decades. So it does beg questions about what's going on here, because actually we've recorded drops in the homicide rate over that same period of time. So it does raise questions about what's happening in the arena of gender. Now, the older work on this, and when I'm thinking here of Radford and Russell's study in 1992, that really was quite a sort of a radical feminist perspective on this work, defined femicide in the following way. the misogynist killing of women by men, and really classifying it as a form ultimately of sexual violence, and obviously as a global issue. And she emphasized the desire for power and dominance and control, either in relationships or more broadly speaking. So in other words, it situates the violence within a broader structure of patriarchy. Now, as a researcher, and there are a number of us who were concerned about some of these very sweeping generalizations, and very important as they were drawing attention to a hugely important issue. We were concerned that, perpetrators were sort of being universally portrayed as sort of foot soldiers in a patriarchal army. And this struck us as just a little bit crude, some of us. This was akin to the oppressor-oppressed model of history that we see, which is profoundly lacking in nuance in some ways. And of course, some of the postmodern feminists and the feminists that would also emphasize the role of colonialism, race and ethnic relations and other things began to challenge some of these older concepts. So the tendency with this language of femicide is to lift the killings out of their socio-historical context. And one might argue, and some people, Judith Butler, who just wrote this book on gender trouble, which was published, I think, in 1991, really accused basically this line of thinking as being about conceptual imperialism. In other words, taking our Western models and plonking them down in so-called third world. So this too was problematic and in and of itself an act of colonialism of sorts. So you might think, well, what do these debates have to do with anything? My old colleague Jacqueline Campbell, who's done some great work on risk, came along with Carol Runyon, one of her colleagues, and said, she used the word femicide differently and basically to refer to the killings of women, which was much simpler because it really, didn't emphasize or infer the intent of the perpetrator, either misogyny or an attempt to assert power, control, and domination. In other words, this left things open a little bit more. And Jackie did us a great service here with this, in that it opened up the floodgates for communities to begin to think about how we might attack these cases and these horrors in community that clearly are profoundly gendered. Let's make no mistake about this. I mean, I talk about battered women to refer to, and there are some people don't like to use that word anymore. I use the term battered women to describe women who've been subject to the hammer of long-term domination and abuse. Grinding, severe violence and near lethal violence at the same time as emotional subjugation, again, over a long period of time. This is to distinguish it from violence that is based in situations, once called by Michael Johnson common couple violence, or to distinguish it from so-called lesser forms of violence. This is not to condone those forms of violence, but it's to distinguish what battering was used to mean. So we're talking about severe violence, and this is where we see the homicides. So this was the slice of cases that we were interested in, and that slice is profoundly gendered. Let's be clear about that. That does not mean that women are not capable of exerting coercive controlling tactics in relationships. Clearly they are sometimes, but their numbers are probably less than 10% of all coercive controllers, according to at least my read of the evidence. But we can go back to that. So we don't want to infer motive. As Judge Carman said, we want communities to be open to exploring these cases with an open mind. And I'll come on to some of these philosophy issues in a moment. But we also have to know other forms of killing that vary across the globe that are directed primarily at women. We want to look at, the question of witchcraft killings, dowry killings in India, armed conflict and gang warfare. I sent an article out on violence against women in Colombia linked to gang killings, something that our friends in El Salvador have experienced too, where one gang kills the female partner of another gang member to get back at the gang, the opposing gang. So again, this varies across the globe. We also see obviously death associated with human trafficking, both labor and sex trafficking. And again, we're working on these issues in El Salvador. It's one of the things that we're trying to do. And then there's this thorny issue of missing women. If you look at the pioneering work of Nobel laureate Amartya Sen, who looked at the phenomenon of missing women and sex-selective abortions in places like India and China, the disproportionate overrepresentation of men in those populations because the boy is preferred to the girl, if I can put it indelicately. This is a remarkable phenomenon. So again, these are things that we have looked at and that we ought to consider depending on where we're doing this work globally. But you can see why the international community is interested in these issues, because where you have large populations of surplus men, especially in economies that are somewhat immiserated and marginalized, you have the makings of a lot of political trouble. And we see national security issues here linked to these things as well, these demographics. Also genital cutting deaths. And these are often related to genital cutting engaged in by older women in communities in all kinds of contexts, but particularly in sub-Saharan Africa. And we also have to look and put this into broad context, because we live in what's called an age of depopulation. And what I mean by that is that for the first time in human history, the population of the world is depopulating. You need 2.1 babies per female, to put it really crudely, to maintain your population at its current level, absent inward migration. We have communities now in South Korea, in Japan, that have ratios below 1. There's a demographic crisis in China with national security implications around the birth rate and the declining birth rate. So this age of depopulation is a very significant issue. We've not seen this since the Black Death in Europe in the 1300s. So that was caused by disease. We don't know what's at the heart of the depopulation movement these days. So it begs really important questions. And economists and historians have been looking at this, sociologists, for decades. And they looked at things like, well, is it related to drops in infant mortality in some way? Who knows? Is it related to secularization? Are people having, it couldn't be. Is it declining secularization? Are people losing the spur of religious thinking, which would encourage people to have families? Are societies becoming more rational? You know, there's a whole bunch of access to contraception. Does that mean that people are having fewer children? Increased education and literacy. Does that mean that people are choosing to have fewer children? What feeds this? And I've listed a whole bunch of these, but all of these were refuted. None of them gelled with the changes globally in the birth rate. Economist Lant Pritchett comes along in 1994 and publishes some pioneering work where he says the most powerful predictor, fertility predictor, is what women want. The international surveys are clear, he says, and this was a very important discovery. The national surveys are clear. Women are choosing not to have as many children. This was published in Population and Demographics. And I've got the footnote. And you have access to my PowerPoint with all the footnotes, so you don't need to take notes necessarily on this. But the one-to-one global correspondence between national fertility levels and the number of babies women want is a very clear, cozy, tight fit. Holds for richer nations, poorer, more urbanized, more religious cultures. The decline is there, even in theocracies like Iran. Women are having fewer and fewer children, even in sub-Saharan Africa. Women, even although they're having much larger numbers of children than elsewhere, women are having fewer and fewer children. And just to put this into maybe broader context, in terms of the work we're doing, there's been a revolution in the last 50 years in family formation. Tony Giddens, British sociologist, famous sociologist Tony Giddens, refers to this as the transformation of intimacy. People are doing intimacy and intimate relations in different ways. The dyads, if we can call them that, are different. The forms have changed. Some people don't like it. The forms have changed. They just have. There's a flight from marriage. People are getting married later. People are living alone more often. This is happening, again, all over the globe. People are also becoming more attuned to their own self-actualization. Now, some might refer to this cynically as the rise of the cult of the individual, to use sort of old Durkheimian language. But these are international trends to different degrees in different cultures. So it begs the question, and it's just a question that I wanted to pose today at this juncture, is what is the relationship between global violence against women, and particularly femicide, the killing of women, and growing global self-actualization tendencies culturally? Is there a connection? And these are bigger picture things that we need to begin to think about internationally. So let's say a few words now about philosophy, because philosophy in this work matters, and it's always been, in my opinion, the most important thing that we talk about when we do Fatality Review. And I've studied the research on this in terms of medical error deaths. We don't know how many medical error deaths there are in the United States each year. Some estimates put it as low as 25,000. Some estimates put it as high as 250,000. And who knows, and again, we don't have a horse in this race, but we want to say that there are a lot of preventable medical error deaths in the United States and across the globe that could be rectified if they reviewed those deaths properly. But they have a hierarchy, an authority set of authority relations in the medical profession that is not conducive to doing thorough, open, transparent reviews where people are vulnerable and they're willing to listen to opinions across the board. In other words, they're not multidisciplinary and they're not multi-perspectival, if I can put it that way, in a genuine way. So we have these deaths. This is a radioactive wolf from Chernobyl. And I always show this, and basically you'll remember this. The Chernobyl explosion in 1986, the nuclear explosion, created this sort of 1,000 square mile zone of exclusion in what was, at that time, the former Soviet Union. It's now the space that Ukraine occupies. No one could live there. The animals were radioactive. You take a Geiger counter in, and that radioactive warfare has 300 times the acceptable level of radioactivity. The Soviets knew for 20 years plus that they had problems in their nuclear industry. They had a series of accidents that they didn't explore, that they didn't review, that they hushed up. They needed nuclear power to combat the threat that they saw from the United States. So there was this huge standoff between these groups. So the result was poor or non-existent reviewing, and it resulted in the Chernobyl explosion, which was catastrophic in terms of its long-term health implications. I remember my mother telling me in 1986 or 7 when I went back to England, Neil, don't drink the wine from Eastern Europe. It's probably not a good idea. So you get my drift. This contamination was quite incredible. Now, I'm drawing this contrast out to make my point, but when we compare this with reviews in aviation, commercial aviation, you'll remember this, I think this was in 2009, and there's a congressional hearing into this, and there's a transcript of it, which I'm happy to send you if you want to read it. It's absolutely fascinating reading. But when Captain Sullenberger and his team and his co-pilot was flying the plane at the time, flew up out of, I think it was LaGuardia, about a minute into the flight, the ascent, he hit a flock of Canada geese, and they burned out both engines. And he had 60 seconds to decide where to park that plane. He took advice from people in the cockpit. And of course, he has this jolt of adrenaline. You imagine, you hear the thud of these big birds on your engine, and you look at your engine lights on the panel, and you see they're gone. And you basically then got to glide that plane down. He's getting information from everywhere, takes advice from his co-pilot, he lands it on the Hudson. Remarkable. Saved all those lives. Now, when he was making public presentations, I'm quoting from one of them, people would say to him, my God, it was just so remarkable, the heroism was remarkable. And he said, it's nothing to do with heroism. This is an instant startle response followed by an instant training response that we spent 40 years perfecting, because we have reviewed crash data for 40 years. We know what to do in these emergency situations. And if you look at commercial aviation and deaths in plane crashes, whether you like flying or not, and I don't particularly care for it anymore, it's much safer than it used to be. So we took this model from the NTSB, and they bring together the avionics people. They bring together the framers of the aircraft, the people who serve drinks, who can look out of the window from a different angle, the co-pilots, the people who sell tickets, the mechanics. All those people come together in a critical environment where they may have different perspectives, and they review those crashes, and they've been doing it for a long time. And when you have that kind of openness and that transparency, you're going to make for better reviews. So the idea that we would somehow assume or infer the logic of a perpetrator who commits these atrocities is counterproductive to actually doing a thoroughgoing review. We want to have an open mind in these things. So we don't want to blame and shame. They soon learn that if you start pointing the finger at people, forget it. They're not going to come to the table. So if we start pointing the finger and saying, so-and-so over here, I don't know, police officer over here had PC to make an arrest, but they didn't make an arrest when they could have done. Or victim advocate over here didn't anticipate this on a safety plan, it was inadequate, or whatever, the judge didn't do this. This kind of stuff is for the birds. And I don't mean that, I guess it's for the Canada geese. You know, you get my drift. This is not productive reviewing philosophy. It just isn't. We want accountability. We want to learn from other fields, because lateral thinking and taking ideas from other sectors is really helpful. The domestic violence movement, in some ways, hasn't done that in a way that it might. We want to create a subculture of safety where people can talk openly about what they think. That means all kinds of ideas. And we put that into this conference. We want to discuss the role of power. But we also want to discuss the role of mental illness or substance abuse or all the other things that our judiciary report they see on a daily basis with these cases. We want to talk about all these different things, not assume that we have the keys to the kingdom. So let's talk about origins and geographical spread. So first of all, when we know the historical origins, we have to note that this came out of the public outcry and the rise of second wave feminism. The feminist, the radical feminist, drawing attention to this issue was hugely important and consequential. And those folks deserve huge credit for this. And we have people, my friend Yanira is here from El Salvador, and I commend her for all her work that she's done in El Salvador, drawing attention to these issues. I mean, there's remarkable work going on. This is really important to acknowledge. But we also look to changes in patterns of women's paid work and education as being an influential context. We have to acknowledge the new civil rights movement in the 1960s in particular. Right? And the original civil rights movement in the US dates all the way back to 1875, of course. But the new one in the 60s was a big deal with Johnson's war on poverty. Increases in divorce, and particularly no-fault divorce, which gave women a lot more maneuverability, but also raised questions about the danger of exiting in a small sliver of cases where there was a homicide. Growing control of women over their reproductive health, as we saw with Lamp Pritchard's data. This was also an important influence. And as Tony Giddens says, the transformation of intimacy was also a very important thing. People were getting sick and tired of some of the old formulas, and they wanted to do things differently. We must acknowledge the passage of the Violence Against Women Act, the bipartisan act that President Biden and Senator Orrin Hatch introduced back in 1994 and got that through. That was a remarkable milestone in this work. The opening up of the Office on Violence Against Women has been hugely consequential and very significant. And the funding streams that came from that have been very significant. This work would not have been funded by private corporations in the same way. And one of the reasons the US state was able to do this was because of its generation, its GDP per capita, which above and beyond that of other nations, enabled it to cream off cash to do this, because it also realized the links between this and human productivity. So we'll talk about that later. But the victim rights revolution as well. The 73 Supreme Court cases were influential, the Victim Rights Act of 2004, all of these things. Now, we see a steady rise here in the number of US states conducting domestic violence fatality reviews. And you can see here roughly over a period from the early 90s right the way through to just last year, we've got now about 45, 46 states doing some semblance of this work. And then if we look internationally, and we should add Scotland on here, we welcome Vicky Carmichael from the Scottish Ministry of Justice. Vicky's here today. Scotland is soon to add to this in terms of actively doing reviews. And Vicky would love to meet with folks. And if you see Vicky around, if we eventually get name tags to you, you'll be able to connect with her. She'd love to talk with you about your experiences. But you can see here that, I'm just learning to use this clicker, but you can see here the way this is developed. And there's a pattern here, obviously. These are wealthier nations. They're wealthier nations, they're democracies, functional democracies, sometimes flawed democracies, but they're democracies nevertheless. They're open, they're transparent to some degree, they're willing to be reflexive in terms of how they look. This would be more difficult to do in authoritarian states. And if we look globally, you know, the famous sociologist Max Weber really, in a nutshell, talked about three different kinds of authority. One was sort of traditional authority, and the traditional authority of the patriarch, the man always knows best. The property is inherited down through the male line, male property rights, the insignificance of women. Traditional authority. Much of human history in some ways followed that form. But we also see charismatic authority that Weber describes as his second kind of authority, which we might see in theocracies like modern-day Iran or Afghanistan or whatever. Now, in both traditional and charismatic authority regimes, women fare much, much less well in terms of being subjected to violence and abuse, and in terms of their personal and political mobility. So these are important issues when we look at the type of society. So if you look at, say, for example, Russia has no specific domestic violence laws. Doesn't mean they don't address domestic violence. They can do it through their assault laws, but they nevertheless don't have that specific category. China only reintroduced domestic violence laws in 2016. That was the same time that China did away with its one child per family policy because it knew it had a pending demographic crisis in terms of replacing its population. There, the depopulation is particularly acute. So this, in some ways, one might say, almost a cynical sop to try to get women back to reproducing by acknowledging the role of domestic violence in their lives. So let's say a few words about team membership, which is my standard bread and butter for these presentations. The key here is eclecticism, variety. We want a lot of different people at the table. You know, we were so slow to learn with a lot of this work. You know, luckily I had many smarter colleagues than me. We were in Montana one day, and a researcher came up to me and said, you know, how come you don't have pastors on that team? And I said, I don't know. And they said, well, you know, I've done research over the last 10 years in rural communities in Montana that tell me that victims of violence, that battered women, share much more with their pastors than they ever do with law enforcement at the scene, and much more than they do with victim advocates, because a small number of them only end up going to shelters at the time. How come you don't have pastors on the team? It was just an oversight. It was ignorance on our part. And there were a number of these examples. And the key is with these teams, look, inclusivity. Inclusivity and creativity. This is the way they made airlines safer. They brought a lot of different people in to do this, and they were open to those things. And you can see the list. I'm not going to read the list out. It's tedious. Now, people, you imagine, I take 6 of you or something and we blindfold you. And then I bring an elephant in and I put you at different points on the elephant. And you're trying to describe what the elephant is. And some of you think, you know, oh, it's a spear, right? You got the tusk there. It's a tree. You got the leg, etc. You get my drift. The domestic violence homicides, the femicides, these cases are complicated. And we want to convey a sense of that to review teams. Because in their complication, if we acknowledge that, we will begin to get at multiple systems. And this is a really important philosophical point. It's not enough to list the agencies that responded in these cases or didn't respond, or the family members or community members who were there who responded or didn't respond. It's insufficient. What we need to know is how those victims of violence navigated their way through those systems or didn't. Because what we see as the delivery of an objective array of services, if you're in a situation where you've been traumatized serially for years, you don't see those services as a logical array. You see them as a confusing, alienating maze. We hear this all the time. So we have to get, I call this a sort of ethnographic gaze. In a way, for the researchers in the audience, this is a form of reconstitutive ethnography. Looking at ways of life and piecing it together. How does the battered woman feel when she goes up to the courthouse to get an order of protection? What's the response to her at the court clerk's desk? What's the response of the judge in the courtroom? What's the demeanor of the police officer at the scene? because the demeanor, the emotional demeanor is what matters as much as the content of what the service might be. So we realize that we have to think carefully. Another way of piecing this stuff together is to look, and I call this the sort of kaleidoscopic approach. It's rather like those little things you used to, remember those little cylinders you used to look through as a kid, and all these beautiful colors. At least I don't know if they have them these days. Probably got them online or something. But anyway, they're beautiful, and you see this sort of mosaic of color and glitter and things. And we need these cases to be sort of kaleidoscopic. We need teams to think about this. If you're doing this work and you're doing it seriously, you're embarking on maybe a 10-year initiative of developing preventive interventions. And you've got to think about your cases and how you review them, not only how you review them in the depth, but how you rotate them and what they might teach you about different systems and how you might meld all that together. And this is a major part of our technical assistance offering through, again, many thanks to OVW. You know, this is the work that we try to do in the field. So obviously the staples are the killing of women by men. Single killings. There are also homicide-suicides. The homicide-suicides are probably going to tell us different things. Those offenders are more likely to be a little bit better off economically. They're more likely to have substance abuse and maybe some mental health problems, not severe mental health. They're maybe more likely to be depressed or suicidal, etc., etc. So these cases tell us slightly different things. The family killings. Now, excuse me, the child death review teams review the deaths of children. Roughly half of the child maltreatment deaths in this country probably are linked to adult woman battery. Adult domestic violence as a context. That's what we found. We did some research on this in Florida. These are important observations. And when children kill their kids, fortunately our kids and our grandkids don't just kill us. They may kill us in our pockets, but they don't kill us. So, we have to think about what these contexts are. Why does the child kill the adult? And what we see when we look at the data, and you look at Paul Mones' work, MONES, Paul used to work in the LA Review Initiative. You look at Paul's work back in the 80s, 9/10 of those kids have been physically, sexually, emotionally abused by those parents. So it's there in the family killings, but the reviews will tell us different things. Sexual competitor killings. Now, we see men killing men over women, not just in a gang setting or a gang context, but we see that happening also in everyday life. Sexual jealousies between new boyfriend, old boyfriend, whatever. We don't see many women killing women over men. There's some snickering at the front. I just want to point out that Jan especially is raising a thumb or something to this one. I've heard from people that men aren't worth it, but of course that's not true. But seriously, again, these case types yield different information. It's like we tilt the lens and the light comes in from a different angle and we see different things. So we have to plan this scope of work carefully. The suicides are a massive issue. They are a massive issue. We reckon that we lose more women to suicide, exiting violent and controlling relationships a year than we do to homicide. And goodness knows how many men we lose to suicide a year. The current CDC total is around 45,000 people a year commit suicide in the United States. Probably 70 to 80% of those are men. We don't know how many of those men are perpetrating domestic violence, or particularly woman battering, or are subject to it. This is a huge chasm in our knowledge that we need teams to work on. Is Sarah Danga here from London, England? Sarah is here, good. So please look for Sarah Danga. She is doing very valuable research on this topic. in the UK. She's published some great work on this. Please seek her out. If you're doing suicide reviews, Sarah wants to speak with you. And we'll have more information at the registration desk on that. But if you've done those reviews, Sarah would like to talk with you. She's the recipient of a scholarship and is a PhD student as well. So please do that if you are. Indirect deaths. The old Philadelphia team, under the leadership of Mimi Rose, a prosecutor, started looking at the deaths of homeless women, HIV, AIDS positive women, drug addicted women, sex workers. All of those women were put into their predicament through family violence and abuse. Many of them, not all. And again, those teams identified those indirect deaths and worked it into their statute and started to explore these things. These are massive public health issues. Much work remains to be done in that arena. The whole arena of near fatalities. Many states now have near fatalities as part of their statutory ability. They can review those cases. Contract killings. We see these, for example, in the Bay Area in San Francisco. We see multiple perpetrators being brought in from overseas, maybe, to kill a young, often a young woman, who is not sticking to the cultural line in terms of her choice of mate or her behavior. And I'm not going to name communities, but we see a number of these across the United States. Bystander deaths, our friends in law enforcement and our friends in advocacy, killed and maimed in these cases. These are takeable cases to review. The Vermont team have pioneered in that area. And again, these are important. We need people on board to do this work. We want to show respect for our professional colleagues who put their lives on the line doing this. And then there's a whole area of other suspicious deaths, accidents, etc. So let me go on. Let me say a few words about the social patterns associated with this. It seems from the data, and Jackie Campbell has published some stuff on this too, which comports with this. It seems from the data and our rather superficial observations that about half the women in this country, in the United States, who die each year in these killings, did not receive very many services. They died in isolation, they didn't reach out, which begs a huge question: why not? Why did they not avail themselves of services? The other group of cases, there was substantial systems contact. I can name a case in Arizona where there were 34 agencies and community groups involved in the handling of that case prior to the killing, but there was greatly reduced communication, coordination, collaboration amongst those various entities. So we see sort of a bipolar distribution here with the cases, but again, when teams are looking at scope, they need to be thinking about, okay, was this a high systems contact? Low systems contact? Again, kaleidoscopically, working this in to think this through over a long-term strategy. These killings are stylized. There are common themes in them. And in terms of relative risk assessment, this is incredibly helpful. It's incredibly helpful when the pioneers in the risk industry identified the fact that strangulations and gun use and these different things corresponded with a greater degree of risk. We have a risk assessment panel on this, but it is absolutely not true. And I was at a conference a few weeks ago where a dignitary, I might say, got up and said, well, he strangled her, he's going to kill her. You know, statistically, epidemiologically, this is nonsense. This is not true. We cannot predict homicide. It's so rare. It's so rare we cannot predict it. So this slogan that's out there, we can predict, therefore we can prevent, this is nonsense. We cannot predict, not in terms of absolute risk. And we will address these issues and the constitutional implications of those issues in our workshop on community-informed risk assessment, which closes out the conference. But as I said earlier, women do better under rational legal authority, not charismatic or traditional authority. They do better under rational legal authority, where there is a rule of law and due process. Women do much, much better, and they're much, much safer globally under those arrangements. They're still not safe, but it's better than the alternative, to be really blunt about it. So anything that besmirches or belittles the rule of law by making false claims is very problematic in the long term. It's also contrary to the spirit of the US Department of Justice, which is there to undermine, to emphasize, to underline the importance of the rule of law. The homicide rate seems to have gone down, maybe 1 percentage point a year if we average it out since the mid-90s. Difficult to say. COVID interfered with our data. This is based on the Violence Policy Center reports over that time, but we seem to have seen a decline. We have most definitely seen a decline in intimate partner violence in general over the last 30 years, a significant decline. And the BJS statistics on that are pretty clear. It's something like 60 or 70% decline. We've also seen a concomitant change in attitudes towards this. We know much more now about how dangerous and how deleterious this is. We don't know why. There's a whole bunch of questions, and teams all think about why there has been this reduction. This is a major development. Is it, the decline is slow, but it's there. Is it due to improvements in arrest, etc.? Orders of protection, shelter work, domestic violence programs, risk assessment, medical services. There are all these options. And again, you have my PowerPoint. We'll put it up. You can just go to it if you have the slightest bit of interest. Can't imagine you would. So the process of reviewing is something that we at the initiative spend a lot of time on. This is where the pedal hits the metal. We obviously want an aggregate sense of deaths. So if I'm dealing with a state or a nation, we will ask, okay, what's your total population? What's your known number of deaths? I mean, these are the big picture questions. And then how are you counting them? Is this a reliable count, et cetera, et cetera? So aggregate stuff. And then teams need to think about, and states need to think about, what their review strategy is with individual cases. Are we going to dig deep? Are we going to spend 2 days, almost like sequestered away in a hotel room somewhere, reviewing this case after spending 3 months doing interviews with various participants? This is the Montana model, for example, the New York model. Phenomenal work these people are doing. We have Mary Walsh is here from New York. She's done, I think, 36 of these. Joan Eliel is here from Montana. And these are pioneers in the field. These are the real people who do the work. And that model is a very impressive model. But so timing, location, funding, etc., number we do in a year, what can we afford to do? All these big picture questions. And then another initiative, and it's just coincidental that we're here at Yavapai County, but we need to think about links to other review initiatives, especially things like suicide death reviews, child maltreatment death reviews, fetal and infant child mortality reviews, COVID death reviews, opioid death reviews. You're sitting in a community that took its adult domestic violence fatality review model and under the leadership of County Attorney Sheila Polk, applied that to opioid death reviews in this community. It's a remarkable transformation. And they've actually got anthropologists interested in the work that they're doing. This is important work, and again, we can learn from different review sectors. Organizing, we're going to have a session, 2 sessions actually, of mock reviews, where we will lead this, but this basically is one of our guidances. We establish timelines, we build red flags analysis, warning signs, knowing we can't predict. We assess the degree of integration of services or lack thereof. We come up with implementable recommendations, and we always, of course, have outstanding questions that we cannot answer. I'm looking at my time here. Thanks, Sue, for putting the clock here. I bought a new watch from Walmart, and it was orange, and I was wearing my orange running shoes, and I thought they matched, but I can't get it. Anyway, whatever. So there we go. This is a sample of a timeline done on an Excel spreadsheet. You can do this in multiple ways. You know more about this than I do. But this, basically time, date column, source column, because always we want to know what's the evidence. How do we know what we know? And then notes on this particular thing. And those of you that work those mock reviews, you'll see this in action. This is our risk assessment that we use in Arizona. You'll have a workshop on this. These are the kinds of markers that we do, that we use in our red flag analysis. And again, I'm just really skimping through this stuff quickly. And again, you can have my PowerPoint. But there are numerous potential data sources. So this varies with statute. This varies with nation. So I can't say much other than to note that you have to use your statutory guidance to gauge the information you can access both legally and ethically. And we have a workshop on that, and it's a very important workshop. We have Lish Aiken running that workshop and Daniel Albright, both of whom are specialists in their field. But you can see the kind of data we use, but we also want to work with survivors and their families. We got a lot of agitation in the early days, and so we should have done. They deserve a seat at the table. They deserve to be integrated into this and to have an important voice in this. They don't get to call the shots for the review. This is a public interest review, but they get a voice, and a very important voice. Survivors, co-workers, neighbors, friends, they're going to tell us stuff. We did a review in Montana many years ago where we did 35 interviews of people in the community on that case. Now, I'm not recommending that for everyone. I'm just saying this is an example of what can be done if you have the will and the energy and the resources. And this is a more thorny issue. The perpetrator's family and the perpetrator. And I'm not going to spend a lot of time on this, but we can learn from perpetrators and their families. And I know some people are going to instantly say, well, they're going to rationalize and justify and excuse their own behavior, and you'd be right, sometimes they do. There are ways of narrowing that down, and we have a perpetrator panel devoted to these issues. We'll talk about ways in which we can minimize some of those effects. But we can get a lot of information from perpetrators and their families. So these are called collateral interviews in general. The interviews that we do to supplement the documentary sources that we have in our reviews. And I've elaborated upon these in my notes to the PowerPoint, but I'm not going to spend a lot of time on this. But clearly, if you're doing the review out of respect for the families who've lost their loved ones, we need to, if you're at the review table, you need as far as possible to review the materials and to do that diligently. It's an onerous, both responsibility and privilege to do that. So preparation is important, and the more prepared you are, the less likely you are to get grief in terms of interviewing a perpetrator and getting this sort of rationalizing, justifying response. Choose your interviewers carefully. Know the case and know your statutory constraints and your ethical constraints. Teams need to have communication about this stuff. Need to think about it. Are we going to print? Are we going to publicize information from cases that could easily be Googled and reveal the identities of the parties and then provide a sort of conduit into the personal aspects of their lives? Lish and Danielle will address these issues. We want to be careful. Some family members don't want to participate. Some family members, between perpetrator and victim families, decedent families, are feuding. You may not want to go there, so there might be some security issues here to think about. And certainly we've encountered some of those. When family members participate and the review is done well, they often report catharsis. They often report a feeling of having contributed something to these horrible cases and to contributing something to other victims who remain. They do not report closure. They've been to hell and back. They've lost. They do not report closure. The review won't give them closure. Reporting back to the team. If you're going to a prison to do an interview, and there are 2 or 3 of you, you report back what you've heard. Maybe you've recorded it. Maybe you haven't. Maybe you've gone through the perpetrator's attorney. Maybe you haven't. Maybe there isn't one. We have a defense attorney who's going to work with us to help us think about how to approach perpetrators who suffer from perpetrator trauma, by the way, well documented, after killing someone. So how do we do that ethically and legally? And I know these are controversial points, and I sometimes get in trouble for saying them. But if we're going to take trauma seriously, we have to take it seriously too with perpetrators. And this is a lovely quote from a colleague of mine about male perpetrators. Many of them have been traumatized. And I don't want to dwell on this. If you look at my old friend David Adams' work, what David found is that there's substantial abuse in the lives of perpetrators. I'm not going to read that to you. I'm tight for time, so I will refer you to that third bullet. You can see nearly all of the women who were subject to an attempted homicide reported, 94% of them reported that their abuser had been abused himself as a child. There's also an important period, an important amount of research on psychiatric problems in these cases. We've got a mental illness panel, which I'll preface in just a moment, but people engaging in psychosis, psychotic behavior. Now, no one's saying that the psychosis caused the killing, but what we're saying is that these are important correlates that provide us with food for thought in terms of doing this analysis. We surely shouldn't be closed off to considering these things. I mean, the biochemical impacts of different medications on people's violent proclivities is well known. So we need to be thoughtful about this and the biology and the sociobiology of intimate partner homicide and violence, unpalatable as it may be for some people. So these ideas that we have about intent and motive and tactics, I mean, if you do in-depth reviews with perpetrators, you may see them in front of you engage in a psychotic break. They may not report that they have the intent that you've inferred to them through your other interviews. They maybe can't remember. They maybe have brain damage. So there are lots of complexities here. So we also are faced with the issue of whether there are unconscious drives towards homicide, of whether there are biological forces at work here, so psychopathology, and then just plain inexplicable. We live in this age of reason, as well as this age of depopulation, and we like to think that we can pinpoint everything, and we can't. There are inexplicable things. Evan Starboy used to say, I don't know what the hell these guys do this. And you know, we're at a loss, but we ought not be closed off to an alternative range of ways of thinking about these issues. We have Dr. Kathleen Ferraro here, who's one of the experts, global experts on interviewing and defending battered women who've killed. And clearly, most women who kill, it seems, from the initial data, certainly from my data in Florida, have been battered. But a significant number haven't, and there are other reasons which I'm listing there. And we have a perpetrator panel which will address some of these issues. We also have the problem of dealing with these folks in these interviews of malingering or faking or lying. And this is a well-known piece of the psychiatric literature, which I'm hoping that we have 2 psychiatrists on the mental health panel who will help us hopefully delve into some of these complicated issues. We also have something known as dissociative amnesia, where people just forget what they've done. They can't go there. A, it's very painful, and B, they've got a memory blockage, and it's a genuine memory blockage. Or there's something known as confabulation, where it's a neurodegenerative problem where the brain actually substitutes perhaps an alternative memory. And again, it's easy to think, well, this is a con job, this is that. And it may be malingering, but it may not be. So these are all parts of the complex presentation of these things. So let me say a few words about confidentiality and ethics before I just introduce the conference. You have to do confidential ethical reviews. This is not legal advice, obviously, but use your state statutes, use your ethical guidelines to make sure you're doing it properly so people don't get harmed. Our motto is, one of our mottos, do no harm. It's like the medical profession, try do no harm. People aren't covering up. These confidentiality shields have not been used to cover up malfeasance. I've been in many reviews where people in similar agencies have called people, well, it could have been done differently, etc. We haven't found significant covering up or corruption. What are some of the outcomes? Judge Carbon was kind enough to point out that the fatality review process is sort of a quintessential and very intense form of coordinated community response, and it is. But as a researcher, as an uptight anal researcher, I have to admit, I would never claim that fatality review has lowered the homicide rate, that it's contributed to lowering the domestic violence rate. I would never say that, because I don't know that as a researcher. So these are very difficult things to research. Coordinated community responses and their impact are very difficult things to research. But I think what we need to acknowledge is that there are different forms of CCRs, and we need to look at the impact of those different forms. So there are 4 sets of guidelines that I have here. One is the development of internal mechanisms within the team to change the workings of the team. So as teams work over a period of 5 to 10 years, they change their internal workings based on the work that they do. And you can see some of this stuff, and I'm really skimming, so I apologize for that. But, then there's the community work, what we do in the community, what changes are made. And you can see there are many potential changes here. And this table comes from a publication that I wrote in, I think it was 2022. And I'm happy to share that. If you email me, I can share that with you. But interventions with victims, how teams change those interventions. And of course, interventions with perpetrators or offenders. And then I think to draw this to a close, the new questions and issues that get raised. Is this about power and control? Is the killing about the expression of power and control? Or is the killing about the powerlessness and the out of control nature, either under control or over control, of the perpetrator? These are the paradoxes, the seeming contradictions of the work that we do. And as Judge Carbon said earlier, this is why some of this work is so frustrating. But it's not just about simple power and control, it's complex. And cutting the power and control wheel with different groupthinks on gay, lesbian, this and that, African American, this and that, isn't going to cut it. We need to go further than that. And the reviews tell us how complicated some of this stuff is. So what about questions like, why doesn't he leave? The emotional isolation of perpetrators, the shame of perpetrators, the links between the shame that they experience and their humiliated fury and the rage that they kill with sometimes. These notions of tactics and intent and strategies, I hear it all the time, but they're problematic. They're inferences based on second or third party interpretations of what's going on. When we talk with perpetrators in prison, I've only talked to probably 40 or 50 of them over my career, and there are people here who talk with many more, you don't see the same simple, oh, that was a strategy. Sometimes you do, sometimes you see other things. You've got to be alive to that. They also challenge notions of things like battered women syndrome or the cycle of violence. Again, we hear this, the inter- and intra-generational cycle of violence. The empirical evidence for this is skimpy. And again, the reviews throw up some of this stuff. Battered women seem to have a lot of resistive maneuverability. Strong sense emerges in these reviews of the complexity of the human condition. And safety planning are always considered. Always considered that you can never know what this offender, this perpetrator is capable of doing. It's very sad. I've reviewed too many cases where People said, oh, he'd never do this. He'd never kill the children. He'd never do this. He'd never do that. Never assume that. Safety planning will have that as a backdrop without paralyzing and alarming already deeply traumatized victims. So the conference looks like this, and I want to thank the family violence team for this. This is the best team I've ever had in 30 years. They are a phenomenal team. They're harder working than me, they're sharper than me, and they keep me on track. I'm just a show horse here. These guys really do the work, and you'll see them at the end, but you'll see them about. They're a phenomenal team. But they helped me put this together. So we have a break coming up soon that Judge Carbon will introduce you to, but we've got a mental health panel, which is linked to suicidality and fatality review. And you'll see the bios in the brochure that you've got, or the packet that you've got. And then in the afternoon, we have concurrent workshops. We've got a mock review option from 1:30 to 4:45. And then running simultaneously alongside that, we've got breakout 1, reviews in Native and Indigenous cultures. We have Pauline Gulliver beaming in from New Zealand, who's done a lot of work with the Maori. We have the only justice of one of the state Supreme Courts, Associate Justice Anne McCabe, talking about missing and murdered Indigenous women. This is a very important panel. We have people from Montana, Jen Murphy, and we have Joan Eliel, who work on that team, who will talk about their pioneering work. Working with families and surviving children, we have Frank Mullane from England, and we have Bianca Harper, who runs our Adolescent and Child Survivor Initiative. It's one of the few in the country, I think it may be the only one in the country, that provides wraparound services for kids orphaned in intimate partner or domestic violence killings, or indeed near deaths. They have about 200 families, I think, on their roll. We have Lish Aiken and Danielle Albright with the confidentiality and ethics issue, which I've already talked about. We have the perpetrator panel. And then day 2, we have a very exciting panel, which I think is going to be very wide-ranging. International perspectives. We have people from Canada, Portugal, New Zealand, UK, obviously the United States, talking about the work that they do, giving you a sense of that. We have a panel on new and emerging teams, very young, talented, and I don't mean that in a condescending way, people working energetically in the field, very exciting, new ways of doing business. They'll be talking there in that second plenary session. All of the sessions in day 2 are plenaries. We have a plenary with long-standing teams, the experienced folks, and then we have a community-informed risk assessment panel to wrap it up. I am at 10:28. I'm going to turn it over to Judge Carbon. I thank you for listening and for coming, and we will do our best to have a good conference for you. Thank you.
Dr. Webstale or Neil, shall I call you now? Dr. Webstale? Yes. Neil? Okay. That was just absolutely fantastic. And I think you can appreciate now truly the breadth and depth of programming that you'll have over the next 2 days. The sessions, the diversity of them, the faculty that we've got here is just tremendous. So many thanks to all the work that you've done to get us here. We are going to take a 15-minute break, and then we're going to return here to the PAC for the balance of the morning for our first plenary panel, as Neil pointed out just a moment ago, on mental health, suicidality, and fatality review. I will ask the panelists to come up here before we break, right after we break here. I did want to point out that all of you should have a gorgeous purple program on your folder here. Inside the folder, you also have the program itself. And inside the program, you have all of the bios, the condensed bios for the faculty. When we do the introductions of our faculty members for the plenaries as well as in the breakouts, they have all agreed that we can do very brief introductions so that we won't be taking a long time away from the opportunity to talk about content for the next couple of days. So it means no disrespect to our faculty members. They all deserve full-on bios, but they've agreed that we can do brief introductions as well. So also inside your folder, manage in a letter. Okay, on the left-hand side of your program, or the folder, excuse me, is a letter from the Vice President. And I think it's worth reading. She really took time to acknowledge the importance of this conference, and I was thrilled that she wrote a letter for this, and congratulations to the team for having that. So with that, we are going to break for 15 minutes. We will come back and we will start promptly at 10:45. So thank you, everybody. introduce them only briefly, just as I mentioned before, out of concern for time for the panel discussion itself. But going west from east, I'll tell you that we have a representative from Montana, then Nebraska, onto Delaware, and across the pond to the UK. So I'm going to introduce them in alphabetical order, and if you would raise your hand. So I'll begin with, she's right on the end here, Ann Boatwright. Ms. Ann Boatwright is a certified nurse, forensic nurse examiner, and serves as the state forensic nurse coordinator for the Nebraska Attorney General's office. She is a member of Nebraska's Fatality Review Committee and is also the incoming president of the International Association of Nurse Examiners. So next to Ms. Boatwright is Dr. Julie Kelso. Dr. Kelso is a board-certified psychiatrist with a focus on public psychiatry and community mental health. She is currently the faculty psychiatrist at Riverstone Health in Montana, where she's been a member of the Montana Fatality Review Commission since 2019. Jumping across the pond, we have Ms. Sarah Danger. Ms. Danger is a doctoral researcher at City St. George's University of London and brings a decade of experience as a consultant specializing in violence against women and girls. And as Neil mentioned, she's published on domestic violence-related suicide and has also traveled extensively to examine different death review models. And finally, Dr. Diane Simpson. Dr. Simpson is the chief psychiatrist for the Delaware Division of Substance Abuse and Mental Health and is a distinguished fellow of the American Psychiatric Association. Her career has focused on aligning community-based services with social and governmental systems. So I want to thank all of our faculty members for agreeing to speak here this morning. And just so that the audience does not think that I am being rude, all of our faculty members for this and all of our other sessions have agreed that we can use their first names when I'm going to be speaking with them otherwise. We're going to try to keep this informal and conversational. I have a number of questions to ask our faculty, and we will have lots of conversation here for about the first 60 minutes. After that, as we explained, we have 30 minutes or roughly that for Q&A. Inside your folders, remember we've talked about these little cards, the staff are going to collect your cards and will read questions for us to answer during the Q&A portion of the program. So if a question comes up, please hold them during the first 60 minutes. If a question comes up, please use your card, write it down, and then you can pass it to the edge of the column here. So I'm going to take my handy dandy clock so I'm not late. And with that, let's open this up. And I'm going to ask each one of you, please, if you could help us understand a little bit more. Can each one of you please tell us how mental health professionals, as each of you are in some way, how mental health professionals can contribute to fatality review? And I'm just going to jump on Julie, if I may. You would like to begin our conversation.
Sure, I'm happy to start, and I'm happy to be here with all of you. So I'm a psychiatrist, and on my plane ride here, I was sitting next to a dentist, and she was not sure what a psychiatrist was, so I'll just start with that. So I went to medical school, like Dr. Simpson went to medical school, and then we spend 4 years in residency, but we do a year in general medicine as well. So we're medical doctors, but also have an area of expertise in mental health.
Dr. Kelso, if I may,
Yes.
I just want to remind us, because of my bad, I didn't before. We are interpreting, and we have 3 fabulous interpreters, Ana, Teresa, and Gabby, who are interpreting for our El Salvadoran guests. So if we can just make sure that we are slowing down just a tad bit for them. The same with questions. When we answer questions, we're going to try to be a little bit slower.
Thank you.
Thank you. I'm so sorry for
Yes,
interrupting.
no, that's a good reminder. So my role on our Fatality Review Commission in Montana is sort of a dual role. We, in our state statute, we have it that we have to have a medical provider and a mental health provider. And so I'm on the committee as well as a licensed clinical social worker. And my role really is, from the medical side, I'm able to interpret autopsy reports or talk screens, or really reach out and talk to physicians who might be involved in the case and kind of translate that medical jargon. Also interpreting from a mental health standpoint, what it might mean if somebody's on a certain medication, or what it might mean if they have a certain diagnosis. And then I think more generally, the social worker and I tried to explain or discuss really just the impact of trauma, because we see so much trauma, the impact of trauma on individuals and how that might be related to the case.
Great, thank you. Diane, would you like to go next?
Thank you. Good morning, everyone. I think one of the things that I'd like to highlight, and along with Dr. Kelso, I provide a lot of the same kinds of insights around medical conditions, medications, anything that really requires a physician point of view. So as a psychiatrist, I'm a physician who specializes in mental illness. I think one of the things that really rose to the surface when we were preparing for this panel was the idea that violence is a behavior. It's not a condition. It's not an illness in and of itself. It's not even an individual symptom. It's a behavior. And human behaviors are complex and multifactorial. There is no one singular reason for a behavior. There may be circumstances where a singular issue is the driver of a behavior, but in general, all behaviors are multifactorial. So you can think of this in your own life. The examples I usually use are typically people can relate to their workout routine, right? Why haven't you increased from 2 times a week to 3 times a week, right? There's a number of reasons why that happens, not the least of which is your own resistance to it, that you're not even really acknowledging to yourself or even putting on your list, right? That there are all kinds of things that we keep out of our own awareness when it comes to behaviors, and they're complicated. In these review panels, your mental health professionals are the people who can help you tease that out. The difference between an actual condition, an actual mental illness, a behavior, a feeling, a thought, an emotion. These are all different things. And that can be parsed out in ways that can be very useful to your reviews, particularly when you're considering trauma histories and circumstantial stressors that may be contributory. Really parsing that out in detail can be useful. I think your mental health professionals are going to be your best resource there.
That's great. I mean, having psychiatrists, in addition, some teams also have psychologists. So bringing that medical background is very, very helpful. I'll call you Annie. Her name is Ann, but I call her Annie. So Ann, what would you like to offer from your standpoint as a forensic nurse?
Yeah, so I'm Annie Boatwright, and I am a forensic nurse. So it's kind of interesting for me to kind of be integrated into this panel as a mental health, quasi-mental health provider, even though my technical title is not. When we were writing our statute in Nebraska, we looked at just including all the different types of disciplines and the types of cases that we were going to see. We recognized pretty quickly that forensic nurses oftentimes will see these patients many times before they end up being a victim of a potential homicide, or they may have even treated the suspect or perpetrator in the case. So having that unique lens of understanding the dynamics of domestic violence, what that looked like, trauma, how our patients experience this, sexual assault as a component, strangulation, and all forms of violence in that way really, I think, has given our team a unique perspective and a way to look at things from a different lens. We also have a forensic pathologist who sits as another medical person. And obviously our forensic pathologist is a physician. So we have both the nursing and physician perspective, which I think kind of just enhances that collaboration and that unique response, because the way I look at something is not necessarily going to be the same way as a physician looks at it, and vice versa. So we can both collaborate and kind of help create that really well-rounded look from a medical perspective.
So I think what you're saying is that we see, or 3 of you so far, mental illness impacts us for both victims and perpetrators both.
Absolutely.
Okay. And sometimes we don't think about that actual dynamic. So, Sarah, let's jump across the pond. You are from the UK. Are there differences there, or what would you like to share in your perspective about the role of mental illness and how you can contribute?
Yeah, I think certainly in my role, I come from domestic abuse practice. So again, I'm not a mental health clinician, and that's not my background. But what we've really tried to understand in our review system in England and Wales is how domestic abuse-related death by suicide, victim suicides, we don't review perpetrator suicides, how they are distinct and how they require a distinct approach to reviewing from a domestic homicide, be that an intimate partner homicide or an adult family homicide. So my role, along with some brilliant colleagues, has been to try and better understand how we focus within those specific reviews around the links between domestic abuse and suicidality. Clearly, there's some really important learning there, and Neil mentioned this big gap around perpetrator suicide, but actually we're currently focused at around victim suicide and those links. And within our panels, we don't have a mental health professional on panel, but we have a representative of mental health services. So they won't necessarily be a clinician, but they do offer understanding of the agency's experiences with that individual and indeed individuals within the review. So they're not necessarily decoding some of the sort of clinical aspects, but they're helping us to better understand those interactions.
Thank you. Let's kind of rewind back just a little bit if we can. Diane, can I ask you, can you define for us what we mean by mental illness?
This is my favorite question on earth, just so you guys know. I do a much better job of explaining what's not a mental illness. So this comes up often, and I think a lot of that is, quite honestly, culturally related. Dr. Google has a lot to say about what's a mental illness and what isn't. No disrespect to Dr. Google. So mental illnesses are very specifically defined, right? In the medical world, we really rely a lot on criteria. Diagnoses are defined by criteria in nearly every area of medicine, and psychiatry is no different. The Diagnostic and Statistical Manual is that Bible of psychiatry that lists all mental illnesses. Those mental illnesses in that book have defined criteria, and the criteria is outlined pretty clearly. And just so you know, that book is, I don't know, in the neighborhood of what, 500 pages? Something ridiculous. The book is also owned by the American Psychiatric Association, and so it's an imperfect novelette. There's a lot of information in there that describes mental illnesses and these conditions. I think there's a twofold problem with the way that the DSM is applied in terms of diagnoses. The first is that the criteria are somewhat subjectively assessed. There's no lab study that will tell me if your mood is significantly elevated. That's for me to decide, right? As a diagnostician, that's for a therapist or a social worker to decide in their clinical assessments. It's subjective. You may say that it's severely elevated. I may say it's moderately elevated. Dr. Kelso may agree with me. We would have to make a conclusion there: mild, moderate, extreme, severe. So the assessment of the criteria is somewhat subjective that way because there are no lab studies for psychiatric conditions. There's no imaging study, there's no blood work, there's no measures consistent with something like blood pressure, right? You have numbers to look at. The number's there or it's not. It's different with mental illness. So the application of the criteria in and of itself is somewhat subjective. That said, years and years and years of training and seeing hundreds of thousands of patients gives you quite a bit of skill in the judgment there. And that's the subject matter expertise that your psychiatrists and psychologists and therapists bring to the table. The second part of it that's somewhat flawed is that psychiatric conditions are not static. So it's not like a neurologic condition that generally decompensates over time, something like a dementia that we know will progressively decline. Psychiatric illnesses don't do that. In general, they wax and wane. So people who have something like schizophrenia will look better some days or some months than they do in others. Their illness may look worse when situational stressors impact that. They may look better when their medications are tweaked quite appropriately. And that's going to change over time. There's also more presentation of symptoms over time. So for example, if you have that elevated mood that I was talking about, I might not see that when I meet you. I might not see that in the year, 2 years, 3 years that I treat you. But the next doctor who treats you might see you in that state, and that changes your diagnosis. So it evolves over time. It becomes more clear to us as clinicians over time. And so those are the two things that I think are really important things to consider around the diagnosis of mental illness. The criteria are fixed. They're somewhat, I wouldn't call them rigid, but they're fixed and unchangeable. They're defined in that book. But the interpretation of what that looks like can change from clinician to clinician and can evolve over time.
Well, I've seen that DSM, it's massive, and I thought that it would define mental illness, but it truly, as you point out, can be very subjective and dependent upon who's contributing to the definition that you're using, and tells me as a judge how important it is to have those with medical background be helping us to understand what's going on. So we've got tough work there. I'd like to ask, Julie, let's start with you if we could. In your opinion, what part does mental illness, now we know more what it is, play in the commission of domestic violence or in the homicides or suicides, or for that matter, near deaths as well? What role do you think it plays, and can you help us understand that?
Yeah, I think, Neil during his talk did a good job of talking about the nuance of this. There are certainly, it's like all of this is complex and a little bit messy, and you'll have people sort of on one side who say, we'll treat mental illness and we'll solve violence, and all violence comes from mental illness. And then on the other side, you have advocates who are trying to reduce stigma by saying there's no association, and you talked about this as well. And so the truth is somewhere in the middle, and there certainly is an association, and we especially see that with psychotic disorders, and particularly symptoms like command auditory hallucinations, where somebody's hearing voices that are telling them to hurt somebody else. This is one of the indications that we would hospitalize somebody. But this elevates your risk of violence. But it can come from being intoxicated by a substance. It can come from a mood disorder or a psychotic disorder. And if you take those disorders and then you add substances on top of them, then you can get a more dangerous and more volatile picture. And we were talking before today about just the regional differences. And in Montana, we've seen more and more substance use as part of the picture when we're reviewing cases. We have a huge problem with methamphetamines, which can cause psychosis and agitation and violence, and all of the things that go along with that, not to mention very, very high rates of alcohol use and opiate use as well. So, but we were talking that Nebraska, it hasn't really seen that as much. So I think it's variable in that too.
Okay. Amy, you want to?
Yeah, and I would just add, we've definitely seen substance abuses within our cases. That is absolutely something that is true. But one thing that we see is, I would say almost exclusively all of our cases have some component of mental health issues in it. Something that we also, I think, as a part of our team has been kind of a unique perspective is we have survivors on our panel who have brought forth kind of a perspective of their mental health and the trauma that they endured and some of the things that they did and said during the time that they were being victimized. To us on the outside might appear as if they were severely mentally ill or, were even maybe potentially perpetrators of this violence. But really, when we peeled back that onion and looked at it from their lens of, I acted in this way because of the trauma and the victimization that I was occurring, it gave us a unique perspective and another layer to our mental health issues that we see every day.
Mm-hmm. Sarah?
Yeah, we certainly see that with our the victims, survivors, or the victims indeed of the domestic abuse related suicide reviews. And we see at times this labelling of victims as having a disorder or a mental illness, and sort of that can be used to explain away the impact of the trauma that they have been subjected to, and actually how the domestic abuse that they have been experiencing, sometimes for many, many years, and in many, many different forms, and the power and control that they have been living with has then exacerbated mental ill health. So whilst they may not have been in that space before, they are becoming unwell because of the abuse. And we have seen high levels of alcohol and drug misuse, both amongst the victims of our reviews, but indeed amongst those perpetrating that abuse too. And that's something we see pretty steadily across our reviews.
What have your experiences been, or your experiences of the profiles of the individuals themselves who've been dying by suicide in the context of domestic violence? And can you talk about any of their interactions with services that they might have engaged prior to their death?
So, and this is my favourite question. And really this stems from the deep research that we've been doing to really better understand the profiles, the vulnerabilities, the needs and the experiences of those being subjected to domestic abuse and dying by suicide, and equally what we've learned about those perpetrating abuse. So forgive me if I just refer to my notes a bit here, but I thought it's really important to get the statistics right from what we know. And to
Sarah, are we going to pay for our interpreters?
Okay.
Slow, it's okay? Perfect, okay.
Thank you. So what we did in our piece of work is we looked at 32 published reviews, not a huge sample size, but we believe everything that was published at the time. And we, like I said, we did focus on victim suicides, that's what we reviewed. We also conducted 36 semi-structured interviews as well with key stakeholders, including families, and we held a family focus group. So, and this was in the England and Wales setting. So we found that 78% of those victims were women, and the majority of perpetrators of abuse were men, which sort of follows the trend of the data around domestic violence and abuse. Most often those men were husbands and ex-partners. 2/3 of those women had dependent children. So this really significant impact too on children. Most common method that they use, which is really unusual for female suicide, was hanging. So that was really something really important that came out of our work. It's really considered a male method. So that was really interesting. Nearly half of those individuals had a prior experience of abuse as an adult. 94% of them did have mental ill health, but it wasn't always well described. So exactly what that means was tricky for us to get to the bottom of. Half of them, though, had a history of self-harm, and 2/3 had a history of suicidal ideation or attempts. Some real opportunities to intervene with these individuals. We did see a significant proportion, as I said, of substance misuse. And really clear evidence, which was quite devastating, of victims navigating really complex needs in plain sight of agencies. We sort of expected to see a relatively low level of interaction, and we didn't. We saw a really high level of interaction. So, for example, 90% of them had had police contact. So these individuals were not invisible to services. Half of them had engaged with specialist domestic abuse services, 2/3 with mental health or counselling support services, and 75% were in regular contact with their general practitioners. So again, lots and lots of opportunities to intervene. I think, as Neil said, homicide can be really, really hard to prevent if you have a motivated perpetrator, but suicide is largely preventable. So for me, it offers this real hopeful area of work where we could potentially save lots of lives. But we just saw this real lack of professional curiosity to make links between domestic abuse, suicidality, suicide, and the connection between those two things. And we found, again, really devastatingly, this end point for these individuals of being ground down. And that wasn't only by the abuse that they were being subjected to, but ground down by their interactions with us in services. In some cases, we did see acute stresses around criminal justice, but moreover, we saw this being ground down. I think that's something that we can all take away as professionals.
So Sarah, are you saying that the systems were not being responsive to them, so they're disclosing abuse and not giving the help they need?
Absolutely. Or they just felt so stuck with that lack of response, or so disillusioned by that lack of response. And I suppose they're not really seeing a way out of the abuse, but they've reached out and they've been minimised. I'll give a really upsetting example, so take care, I suppose. But a woman who had been going to her general practitioner, she disclosed previous abuse in a previous relationship, newly married, disclosed abuse in that relationship. She lost a significant amount of weight. So she disclosed to him, and she just, he'd weighed her, she was quite unwell. So she'd lost about, trying to make the conversion, about 36 pounds worth of weight very quickly. And in her notes, he noted that she was a large lady and her weight loss was to be welcomed. So she's gone to him, she's disclosed, she's asked for help, and that is the response that she's received. And so you can see how a woman might feel really ground down by that kind of response from someone who she hoped would help her.
That's really devastating to think, and it makes us question our own systems. What are we doing, and how examine what we're doing and ask ourselves, are we being helpful or not? And that requires us to talk to survivors to see what kind of help are we getting. So Annie, give us your thoughts on this as well, if you would.
Yeah, so in Nebraska, we started our team just a few years ago, so we are a newer team, and our domestic fatality review team coordinator, Amy, is here, and she'll actually speak with you tomorrow a little bit more about our team and kind of some of the successes that we've had. We are reviewing suicides currently, and we feel like it's something that we really are committed to. We are only reviewing victim suicides. It's very difficult to be able to identify those victim suicides just because they're not going to be as out there, and she'll talk more about that tomorrow. But one thing I'll just tell you anecdotally, so even though our team is newer, I've been a practicing forensic nurse since 2009. And I would see patients of domestic violence, sexual assault, trafficking, and they would come in for their abuse. And I could always tell when there was something more that I was missing with them, whether it was that they verbalized that they had a plan around suicide or not. But you could always kind of see in them just how that victimization had worn them down over the years and the things that they were experiencing. And I really felt like anybody who's done systems work knows how difficult it can be for a victim to come forward and fight against the ocean. I use the analogy of these victims are one people trying to warm the ocean's temperature with just their body heat. It takes a village of all of us to come around those victims, take a deep dive, look at what our systems are doing and how we're setting up to support victims, to Sarah's point, because they can't warm the ocean's body temp by themselves. It cannot happen. It has to be all of us together with them fighting. Then we have a fighting chance at this, and then we can really start to make impactful changes so that they're not alone in this. So,
Sarah, did you want to add something? Okay. Okay, go ahead.
Well, I don't know that I can speak to too much of what's happening in the fatality review community around this because I'm super new. In fact, I haven't done a review and I just joined my team last month, so maybe my team can chime in. But I wanted to say about systems and suicidal behavior that oftentimes people who come to us with a high risk of suicide are deeply hesitant to provide any information about their thoughts. And many times they're aware of what's going to happen to them if they disclose those thoughts. And this is where it becomes, I think, very troublesome for us as treatment providers to make decisions about how to best support someone who is hesitant or reluctant to talk about it, because then we become, we're sort of put in that place of the decider again, right? Using that subjective judgment. And in all of the states in the US, psychiatrists are obligated by ethic and by law to hospitalize someone who's a danger to themselves. And so if my suspicion is that high and the person doesn't really want to talk to me about it, I still have to involuntarily treat them and assess them and get them into a system that can try to help them, which is a deeply disconcerting thing to have to do, but it's also unbelievably upsetting to the person who is hesitant to ask for help. So that can be a confounding factor, and I think it's a systemic problem. It's a challenge for all of us, and I think that has to do with where we are legally, ethically, our state code. That might even get into the next question about confinement and restrictive treatment.
Can I just, sorry, quickly come in again? I think one of the challenges that we see in England and Wales is not asking. So actually not asking questions about suicidality. And I think we focus very much in the domestic violence and abuse world on risk from a perpetrator. And all of our risk assessment is based on risk from perpetrator. On our risk assessment checklist, we have one question, are you depressed or suicidal, as if they're the same thing, and it's a yes/no tick question, and actually if someone answers yes, no one really delves very much deeper than that to understand what we're talking about. So I think we're constantly assessing risk from perpetrator and actually probably never really delving in very deeply about risk to self, and therein lies part of the problem, in that these largely women aren't even being recognised as having any kind of suicidation or risk. And so they're not being treated, perhaps they might not want to be treated in that way, but not being treated at all. And that's really problematic then. And then everyone's really surprised that they've taken their own lives. But actually, we had lots of information, we just didn't do much with it.
I think a lot of people assume that suicide is the end of the spectrum of depression, and you point out that they're not one and the same. So maybe also help folks understand that a little bit too. I also wanted just to comment on, Diana, what you said. I think our hospitalization system in this country really suffers. And so from a psychiatrist standpoint, knowing that you have to involuntarily commit somebody, that's got to be tough from your standpoint to do as well. And Sarah, you just mentioned that you have a couple of questions that you might ask. I know physicians now, and worked a number of years ago, to have a screening tool to ask all these checklist questions, and sometimes it's done very well, sometimes it's done in front of the perpetrator and not so well. But is there a process that you can do it in a way? I mean, Diane, you just commented on how challenging it is, because if they do disclose they're suicidal, then you've got that ethical obligation. Is there any other way of gauging and then being able to help short of commitment or not?
I can speak to that. I work at a federally qualified health center, primarily family medicine physicians, and I see patients and do consultation and teach residents. And the way that it's handled is, there is a screener and then sort of follow-up screening. And we have a integrated behavioral health model, which is a push across the country to embed behavioral health services within primary care, so that if there is, a lot of times our primary care doctors have 15 minutes or 20 minutes to address an issue, and that's not nearly enough time to assess somebody's safety. And so we have mental health therapists that can come meet that patient, meet them right there, and do a fuller evaluation and risk assessment, and then make sure that they have follow-up. And then we check in on them, a week after the visit, and make sure they have follow-up and a plan for treatment. So I think that's integrating behavioral health into primary care is one really good way to address it.
And I would just add into that too, from the forensic nursing perspective, we have patients that come in to get care, obviously typically related to when they've been victimized. And so we also are trying to push that model of integrating that behavioral health response. Sometimes it's in an emergency room setting, but then connecting them with resources too. Nurses can kind of sometimes be that glue that is able to connect to your mental health support or law enforcement if we need to, psychiatry, however that needs to look, we can be that person along with helping make that patient not have to, again, fight the ocean by themselves and figure out, well, how do I even disclose that I do have these suicidal thoughts, or where would I even get into a therapist and how would that look? Along with sometimes there's complex issues with the CPS system, your Child Protective Service system, where victims also, factor in and feel like, oh, the perpetrator, if I disclose this information, is going to utilize this against me in a way so that my mental health is now on the front and center stage in our, divorce proceedings, custody issues, et cetera, et cetera. So we can help in that way as well. And I would encourage all of you, I know that I'm like, this is my soapbox, but get to know a forensic nurse, integrate them into your panels and your discussions, because they really can be very helpful.
Can I just come in? I think it's so important that fear and the stigma that we see around disclosing any kind of suicidal thought or self-harm around the risk of losing your children. And we see that time and time again. It was a real trend that we saw in the reviews that we looked at, where children were removed from mothers for lots of different reasons, often to safeguard those children, and absolutely the right response. But then we didn't look after mum after her children had been removed. So we saw lots of reports where children were recognised as being a protective factor for that woman. We, as a state, remove her children from her in order to keep them safe, and then we actually don't safeguard her from herself. And I think there's a lot of fear around disclosure, because what that might mean in terms of a woman's children, and a woman experiencing domestic violence, and men just, experiencing domestic violence, are very used to minimising their experiences, and so minimising their mental ill health is not a giant leap for them either. So I think it's being really live to what they're not saying in the negative space and what that could mean for them, and that real fear around actually saying, this is how I'm feeling and I need help.
And we see that as a tool of perpetrators in court a lot, saying that the victim mother has got mental health, she's crazy, she's whatever, and then people removing the children for that. So they've not only been victimized, but then if there's not a service for them to go to, then we really have left them hanging. So I want to just ask you, it's not my list of questions here, but let me ask anyway, about the availability of resources. How tough is it for somebody to actually get a resource? I know that in New Hampshire, where I'm from, resources are really tight, and it's difficult to, we want to make connections, especially in CPS, we want to make those connections. How readily available are they, and what kind of constraints are we faced with? Actually, accessing mental health services.
I can go right. I'll go. I think it depends, to be totally honest with you. It depends on what community you're in and what that looks like. So Nebraska specifically, and I have a little bit of a unique perspective just because I do some of the work with the International Association of Forensic Nurses too, so I do get a look at that. But in Nebraska, our urban areas, Omaha being about a metro area of about 1 million people, we don't have a hospital in the Omaha metro area that doesn't have 24/7 forensic nursing response. It's crazy. 1 million people, Nebraska, we figured it out, okay? There's my bad joke, so that you don't leave crying. But in our rural communities, it looks a lot different. And one of the things that I've said is really important as we look at systems response and building is creating environments where we might not have 24/7 forensic nursing, capability at every single hospital. But let's break down what the response needs to be. So is that, we're going to transfer a patient? Okay, let's talk about that. Let's set that up so that at 3 a.m, we're not trying to figure that out. Or maybe it's a telehealth model. So our telesane has kind of risen significantly through COVID. So providing forensic nurses or mental health support through that telehealth model, how does that look? So that we can fill in these gaps and create better response and structure. Nothing's perfect. Nowhere is it perfect. If you've got it perfect, I want to know where you're getting your money. Because I'd like some, okay? So. But I always say that is like my tagline. If Nebraska can figure this out, anybody can. You really can. So.
So one of the things that is an issue in Montana is we really have a shortage of, and I know it is across the United States, but in Montana, we have about half the number of psychiatrists per capita than the national average, one of the highest suicide rates. And so we have been incorporating what's called the collaborative care model, and it's out of the University of Washington. And so what this looks like is most of the care in our state for mental health comes from primary care doctors. They are on the front lines delivering most of the mental health care. And so my role where I work is I will provide support to them along with the rest of the behavioral health team. And I spend a lot of time reviewing cases as part of a multidisciplinary team to provide recommendations back to the primary care doctor who has the relationship with the patient. So in that way, I can maybe review and provide recommendations for 14 patients in an hour, whereas if I were just had a regular schedule, I would have one person in that hour and they may not come. So it's really a way to expand knowledge. And so that's one of the things we're really working on in terms of access.
Diane, sure.
I just want to add one thing. Whenever we talk about, access to services, my response to that is always, well, what kind of insurance do they have or not have? Because, in this country, everyone gets care where their payer wants them to get care and from who their payer wants them to get it from, in whatever network that might be. For someone who is uninsured, that would generally be state pay services with state pay providers and state pay programs and clinics. It may be someone who is Medicaid, maybe eligible, but doesn't have it. Maybe they do have it, and they need to go where their managed care organization wants them to go for starting with some acute care, maybe some inpatient and stepping down from there, et cetera. So the payer model can drive a lot of the service decisions, and that's incredibly difficult for individual providers to track on and be aware of who can go where, when they can go where. We generally leave that to discharge planners and social workers, which makes it even more difficult. I may make a recommendation about a certain level of care, and then I'm reliant on a discharge planner to find one that's adequate and would meet my expectations for that level of care. So that's an added challenge when we talk about services.
Sarah, is it any different in the UK?
Well, we have the National Health Service, but unfortunately it's absolutely on its knees. Every one of our statutory services is on its knees after a long period of austerity, and actually you're very lucky if you can access any kind of service without waiting an exceptionally long time. So then it falls to charities, non-profits to attempt to fill the gap. Violence against women and girls sector has been significantly underfunded for a significant period of time. They're doing a huge amount with very, very little, and they're absolutely exhausted. And of course that impacts on the services available. Every service is doing the absolute best they can possibly do with the resource that they have. We simply do not have enough resource, and individuals delivering those services are burnt out. And so we're losing them from the sector in droves. So I think then of course you lose that expertise, that organisational memory that helps us to really shape services that deliver what victims need. So unfortunately we're in a period where our system is broken on in different ways, but on many levels, and we need to start rebuilding. But I think when you need to wait 12 months for an assessment or 12 months to access talking therapy, you need to self-refer. And I think when you are having those experiences of domestic abuse, self-referring to a talking therapy can be really difficult and actually just inaccessible, depending on the sort of the circumstances of your abuse. So there's a real issue with access.
Thanks. I'd like to wrap up with our one last question before we open it up for Q&A. And that is, what role does the treatment of mental illness have in the prevention of homicide? And Neil gave us a big red flag caution here, but what role, if any, does it have? And to what extent can treatment have a positive impact on? So Diane, would you like to start with that one?
It depends. So there are mental illnesses that are highly manageable and modifiable with medications and therapies, and most patients do very well if they are able to adhere to those treatments. There are also mental health conditions, generally in the category of things like personality disorders, that are very difficult to modify. There's very little we can do with medications to impact those. And the talk therapies require cooperation and motivation and engagement. And, you know, generally if somebody doesn't really feel like they have a problem at all, they're not going to be engaged in that treatment. So it really depends on the type of, I lost it, there we go. We do have conditions, a lot of success with what we consider treatable conditions with medications. And I will say for when we're speaking about issues like violence, there are, well, there is one medication that can be useful, two actually, lithium and clozaril, that can be useful in impacting violent and aggressive behaviors. The actual mechanism for that is relatively unclear, and those are difficult medications to manage and require a lot of cooperation from the patient. So again, that the ability to cooperate with treatment is a significant part of whether or not the treatment is successful.
And that in and of itself would create challenges, so and assuming somebody's got access to that. Julie, what would you like to add on?
I think on a more specific level, I just, from the clinic that I work in, and I know that there's a lot of people here doing a lot of interesting things, so I'm really interested to learn what other people are doing as well. We try to, and this is not perfect, but we try to set it up so that our clinic is a safe place for people to come. And so we have protocols in place. So if there's a victim of violence or somebody that's being trafficked, that they're able to have a different name on their medical record, they're able to come straight back and not have to wait in the waiting room. I mean, just kind of small things like that to try to keep people safe. And then we're really trying to train up this next generation of physicians to be able to recognize when somebody has, concerning signs that look like it might be related to violence, how to ask those hard questions, how to support that person and link them to services. And so there's a lot of education that we're trying to do with this next generation of physicians that in my day, we didn't get any training or education on that. And then on a, downstream, we're working on really focusing on positive childhood experiences. So we know, adverse childhood experiences increase your rate of mental health conditions and physical health conditions and risk of violence. And really some of those can be offset by positive childhood experiences. And those are a set of 7 things that are really things like feeling supported in your family, having 2 other adults outside of your parents who take an interest in you, being enjoying community traditions or have a sense of belonging in high school. So really understanding these things and then figuring out how we in the office in that visit can help support parents and provide education and really kind of reinforce and bolster that, knowing too that this is in the backdrop of a lot of housing and food insecurity, and people's environments also need to change. So that's a bigger system issue that I think is a problem that I'm not sure how to solve.
Sarah, before I go to you, Julie, some people may not understand what ACEs are. Can you just take a second to explain to make sure everybody's got that common understanding?
Sure. So adverse childhood experiences, this was a very large study that was done by Kaiser in the 90s, looking at a set of experiences in child and it looked at, household dysfunction, neglect and abuse. Having a parent who was incarcerated would give you a point. Having a parent who had a mental illness or a substance use disorder would give you a point. And it wasn't all encompassing of all adverse experiences, but it was so striking that the more adverse childhood experiences you had, the more likely you were to have not just mental illness and severe mental illness, but serious medical issues as well. And that connection was just so staggering that people really started to look at that connection. And so that's sort of what we're addressing.
It's not a causation, but it's a correlation.
Absolutely.
And I think across the board, all of us have got, I think across the human population, everybody's got some ACE of some kind. But it was the elevated levels that were really remarkable in that work that got us thinking about it. It was also interesting to hear the resilience factors to contrast against that and how we can support better mental health in the population. So Sarah, let me turn to you, and then I want to ask Alvin just one last question as well.
So I wanted to just spend a moment thinking about what you would call like a better intervention program, which we in the UK would call behaviour change, work with those perpetrating abuse. And my last role in DA practice was as a CEO of an organisation delivering behaviour change. And one of the really striking things that we saw in the group work programme with men perpetrating abuse was this really significant history of trauma. And, it does not excuse violence, as you said, it's not causation, but actually it's about really understanding their experiences to support them to change their abusive behaviours, which of course is ultimately to the benefit of those victims and indeed their children. And we talked about compassion without collusion. And I think that's really so important when we're thinking about how we can better support those perpetrating abuse, to recognise their experience and be compassionate, but not to collude with the abuse that they're perpetrating.
You've all touched a little bit on children, and anything else you'd like to comment on the mental health with children and how we might do some prevention, and then we'll open it up for Q&A.
So I'll just kick us off here, but one of the things that we see in my world as a forensic nurse is children or even adults who experience sexual violence or domestic violence are actually more likely to become a victim again. So not necessarily even from the same perpetrator. We definitely want to provide those interventions and that support, whether it be mental health support, resources, that restorative justice type model, so that we can come around that victim and hopefully prevent them from ending up becoming a repeat victim when it comes to these types of victimization. So I think that that's something that we really need to take a look at and kind of own a little bit more. When children are becoming victims, it's really important that we're kind of doing intervention early. In Nebraska specifically, I track all sexual assaults that we pay for across Nebraska. And we have found that our highest percentage of people who are requiring a medical forensic exam by a forensic nurse is under the age of 12 years old. It is. And that's not because everybody in Nebraska is terrible and we're sexually assaulting all of our children. I think that they come in more often and we are getting those reports more often, which is good. But I also look at it as an opportunity. Those children are the children that we need to be providing opportunities to, wrapping in resources and doing better for the future, so that they don't end up in situations of sexual violence or domestic violence later in life. So I look at each one of those people as an opportunity to kind of help support and do better by in the future. And some of our lower numbers are in our adult categories. And we know that there's probably some decreased reporting. But again, that opportunity that we get with those children early on is really key to us being able to hopefully prevent them from experiencing violence later.
I think another important point when talking about children is supporting parents and providing education to parents. And so one of the things that we're doing is a program that's called Keystones for Development, and it's out of Mount Sinai. And it's really about educating and supporting parents and providing this education during child checks from 0 to age 4, where they get a lot of resources and information that talk about neuroscience and brain development in a very accessible way, but also really looking at supporting emotional regulation, attachment, self-efficacy, and knowledge in children starting from a very early age. So that's an area I think of real hope, is how can we support parents and giving them all of the tools and education.
Great suggestion. Sarah?
I think I'm going to come at it from a slightly different lens and thinking about reviewing domestic abuse-related suicides, particularly for victim suicides, and how important those reviews are for children. And I think partly for me that's about a review being a lasting narrative of their mother's life, and helping them perhaps at some point in the future to better understand their mother's experience. Suicide for children is obviously devastating, and depending on their age can be very difficult to understand or to be able to process. And unfortunately, certainly in England Wales, we don't have a huge amount of support in place for those children, particularly very specific focused support. So I think for me, it's a call to arms in terms of reviewing these deaths, is that thinking about what your review can do to tell that victim's story to her children in the future, should they want to access that report, and what that could perhaps bring to them as they move through their lives, so that they're not negatively impacted or as negatively impacted from their experiences as children.
Certainly the trauma a child endures from the death of a parent is just phenomenal, especially the double homicide as well. It's even worse. So thanks for raising that point. Diane?
I think in terms of childhood trauma and adverse childhood experiences, the sheer prevalence that we're finding, the amount of trauma that adults report in their history, the amount that we see with children now that we know what we're looking for and asking is so significant, that helping children develop resiliency is, in my mind, the key to creating more resilient adults. So I think one of the things that I've learned I had a great mentor when I was younger who said that predictive factors are not prognostic factors because of protective factors. And so helping children learn protective factors is a really significant part of the work that we do. And I think simple things like a lexicon of language around feelings. Many children don't have anyone helping them talk about their feelings. They can't describe them. They don't know what they're feeling. They don't know how to tolerate distressful or difficult feelings. Many of them are in households and surrounded by adults that don't tolerate distressful feelings very well either. So this is a new concept for the populace, not just for the children of our time. And it's something that I think we can all think about, just developing those resilient skills.
Excellent, thank you very much. We're now going to turn to all of you. You've all got your cards, and I've seen a couple people pick, but I can't see people. So I'm going to rely upon you all out there to get your mics and start reading questions, because we can't see who you are.
No problem, Judge Carmen. Colin King with the Family Violence Center. And thank you for this wonderful panel, the panel of experts. This was really an engaging topic and really spurred a lot of questions from the audience. So unfortunately, we're not going to be able to get through all of them because you really sent some excellent questions our way. If we're not able to get to it during the panel, please seek out the panelists or any of us to follow up. So first question, Judge and the panelists, can you talk about how we might confuse what appears to be intent to kill with a psychotic break where the offender has no memory of killing?
I'm going to let you all self-select, because you are the experts, not me. Who would like to field that one?
Well, I can speak a little bit to how we assess psychosis. And so Dr. Kelso already spoke to some of the symptomatology of psychosis, which is one of the most prominent features is command auditory hallucinations, which is the voices telling someone what to do. Psychotic disorders in general represent sort of a break from reality. In other words, the person who is experiencing the psychosis isn't interpreting the real world around them the same way that everyone else is. Their lens and their perspective and their thoughts have been distorted in ways that they can't take that information in and assess it the way that somebody who is not psychotic does. And that happens through a number of traditional psychotic symptoms. Auditory hallucinations is one of them. Visual hallucinations can be experienced as well, although they're more rare in psychiatric conditions. There's all kinds of delusional problems, constructs of beliefs that people develop that are fixed but not true. That would be things like, my spouse is possessed by Satan and is going to kill me, and I need to kill them first so they won't destroy the world. This is a common delusion. It's not an unusual delusion. That can become increasingly difficult for someone to sort of manage and assess what's really happening versus what is not. And a psychosis can fluctuate, like I said. So there are many people who have psychotic disorders and psychotic symptoms who can tell the difference. I've treated a lot of people with schizophrenia who have auditory hallucinations 24/7 and are quite comfortable with them. They kind of keep them company and they're not bothered by it. There are other people who feel compelled to follow the instruction, feel compelled to do something about that, and reach a level of sort of an inability to resist the commands. So it can vary quite a bit. You may want to add to sort of what psychosis looks like.
No, I think you did a great job explaining that. I think sorting that out can be difficult. I think it's helpful to understand somebody's history, their treatment history, and whether they've gotten treatment before. We sort of think of things in terms of a differential diagnosis. So and this is across medicine, if somebody comes in with a symptom or a condition or an event, we're thinking, okay, what would be the medical causes that could contribute to this? What would be and that could be a metabolic derangement, that could be a neurologic condition, I mean, you name it. And then what substances or medications could be contributing to this? And then we look at other mental health conditions. So I think a very careful, thoughtful history that includes collateral information from other people is kind of the key to sorting out that difficult assessment.
Thank you both. Colin, do you have another question?
I do indeed. The next audience question is, what recommendations can you give to teams to ensure that collateral interviews do not re-traumatize interviewees, such as family members and friends?
Great question. Annie, why don't you go for it?
So I think our team has done a really great job of positioning certain people to do certain types of interviews. So whether that be we have, some of our LMHPs or forensic interviewer backgrounds doing family type interviews, I think has led to a lot of success in that realm. When we have a suspect, sometimes we'll send that LMHP with a law enforcement officer to kind of have that different background. If we're interviewing a healthcare provider, we send that. So I think that specifically, when we're talking about traumatizing different people, I think it's really important to use a trauma-informed approach and take that lens of, we're never going to force anybody to answer certain questions. We're never going to try and, make them do an interview with us. It's always going to be the person-led, and they're going to, provide us with whatever information they want to provide us with, and we're never going to force anything in that way. So
That's great. Great. Colin, have you got another question?
I do.
Great.
In the state of Montana, or like Montana, with a significant indigenous population, what cultural considerations do you include in your data collection methods or your team member recruitments?
Well, there's members of the Montana team here who are going to be on the Indigenous panel, and I think they could speak to that much better than I could. So I'm going to wait and encourage all of you to go to that panel.
Yeah, I think that'd be a great question to ask for the next panel that we have this afternoon. Plug for our panel on after lunch.
Excellent. In your experience, what has been the role of the local church in supporting and improving the mental health of the victims?
So we haven't actually, in Nebraska, we haven't included specifically a pastor on our team per se. We felt in the cases that we were reviewing, it was important to take a look at each individual case and then pull in the people that were most appropriate. So in the cases that we review, we may have someone, a survivor, let's say, from a specific background or community, whether that be an Indigenous community or someone of the LGBTQ population, IA+, but something of that nature to make sure that we are representing that background in that way, I think is really important. So I can't speak specifically to the religious component, but I felt like that would kind of apply and be helpful.
In Montana, we do have a chaplain on our team, and then we travel to the site where the fatality occurred. And so as part of that, we invite community members. So if there was a pastor or member of the religious community that had been involved with the individual or family, we would invite them to the review and really try to get their perspective and understand that community perspective.
And Nebraska is the same. Sorry, I failed to mention that.
Very nice. Okay, and the panel did discuss this a bit, but I think this question drills down a bit more related to, and here's the question. There seems to be a suggestion that it's an assessment of DV or child abuse. Can the panel please speak to the intersection of assessments, impacting both child abuse and DV?
Sarah?
Certainly within our reviews, we the amount of information included about previous experiences of abuse will be greater or lesser depending on the approach taken by the specific panel reviewing. So certainly when we looked at the victim suicide reviews, in some cases we had quite a lot of information about previous experiences of abuse, so that might include child sexual abuse, domestic abuse as a child. However, in other cases we had very little detail and not necessarily a huge amount of analysis of how that experience of abuse might have then impacted on their experience of domestic abuse as an adult. So our reviews can be different in their approach, so there's sometimes some inconsistency on what we can learn from those reviews. As we're learning about this specific area of work, we're getting better in our reviewing of them, of course, like we all grow in terms of our practice. So I think we will continue to learn more and more about how those things intersect, but probably now we don't know enough.
I would just add to that too. This is just the broader landscape, I think, of victimization from the forensic nurse's lens. But I think as we move forward in the future, parsing out victimization is going to inhibit, I think, kind of how we are able to build up systems, provide support to victims, whether it be, even I'm going to take it a step further beyond child abuse and domestic abuse, but when we parcel out trafficking, sexual assault, any of these things, they all intersect and overlap. And so I think that our systems have to integrate and be willing to take a look at all facets of it as we move forward.
And I'll just add to that, we have to be careful not to put things in silos and treat them as though they are distinct. There is such intersectionality and such a continuum of violence from early to elderly. So it's a global lifetime phenomenon.
Okay, and I think we have time for at least one more question here. So in intimate partner suicide reviews, is there a more or most prevalent factor or factors? And if so, what has been identified as a best practice for addressing these factors? So put into another way, is there gaps that you find based off of these reviews, and how do you address the gaps in those reviews?
So from the research that we did, bearing in mind it was a relatively small sample, if we did it again it would be double. The biggest issue that we saw was a lack of connection between domestic abuse, suicide, suicidality, how they intersect and how they might connect. And because we weren't asking those questions, we were thinking only about, will he kill her? What's her risk of harm from the perpetrator? And not thinking about risk of harm to self. So I think that has come out really, really strongly across our reviews. But this is really new emerging work. You know, we've probably got 100+ reviews somewhere in the process, but we simply don't know enough. There isn't enough research. We don't know enough about impact on children, about potential children's suicide in relation to domestic abuse. No one's counting. So, you know, there's momentum shift, and I think there's lots of work being done. Some teams here doing these reviews, but we need to know more. We need more evidence before we can start really identifying patterns. But the emerging pattern is around just a lack of professional curiosity around the connection between domestic abuse and suicide, and needing a causal factor. And suicide is really complex. It's nearly impossible to say that one thing has caused someone to die by suicide, so understanding it might be one of many factors, but we need to understand that it is a significant risk factor.
Okay, well, maybe, so we have time for one more because it kind of tags on to what you were just saying. Were a lot of the suicides in IPV situations still actively in an abusive situation or relationship, or were there survivors who had recently left that relationship?
It was a mix. I can't give you the exact stats. I'd have to go and look them up. It was a mix. I think what was concerning was the previous history. And the other really concerning thing was that the perpetrators of abuse are more often than not within the community, without charge, without prosecution, without conviction. And what we do know is they were continuing to perpetrate abuse against other women. So that's quite a significant concern, most for serial perpetrators of abuse.
And in Nebraska, we set it up so that our team reviews suicides, IPV suicides of victims within, if they've obtained a protection order within 2 years. And there's a couple other factors too that we take a look at, and I know our coordinator will speak more about that tomorrow, but that is something that if someone has accessed services, you know, related to domestic abuse, we do review that in that way.
Okay, I think our time for the panel is up. If we can please thank this amazing panel. My wish is to clone the four of you, bring you to New Hampshire, put you on our team. It was just fabulous. Thank you all so much for your contributions here, and a way to kick off the conference with our first plenary, so thank you. So we're going to take a break now for lunch. We have until 1:30 for lunch. Those of you who are, in fact, if you recall, Neil mentioned this afternoon that there is a mock review that will be from 1:30 to 4:30, thereabouts 4:45, or you have the option to choose from 2 different concurrent workshop sessions. One that'll be 1:30 to 3, and the other one from 3:15 to 4:45. One or the other. So either you're in the mock review or you're going to be attending 2 different breakout sessions. For those of you who are going to be participating in the mock review, we're going to have a staggered lunch and ask the rest of us to stay back and let those going to the mock review get your lunch first. Because lunch is being served in Building 19. If you look at your map inside the folder, Building 19, which is just up the hill on the left, is where we will have lunch. Everybody will have lunch there. You can eat outside, inside as you wish. You are welcome to go off-site if you choose to go off-site, but lunch is provided if you would like to join your colleagues here and have lunch with all of us. Then after we've given that group a little bit of time, the rest of us will go to have lunch. This afternoon then, we have 2 different panels at 1:30. The first is reviews in Native, Indian, and Indigenous communities. That will be in Building 4, room 104. The other session is working with families and surviving children. That will be in building 3, room 119. There'll be a break, and then we'll have the second concurrent session. One panel will be on confidentiality and ethical issues. Again, the building and room numbers are in your programs and they're posted outside. The second panel will be perpetrator involvement in fatality reviews. If you get lost, people with yellow lanyards, not purple like mine, yellow lanyards are staff. They can help guide you around campus if you need any directions as well. Later this afternoon, at the end of the day, we have back at 5:15 back in this building, we call it the Performing Arts Center of the PAC. We will be back here at 5:15. We invite you to an informal cash bar reception so that you can have a drink with your colleagues before you head back to your hotels for dinner and however you choose to spend the rest of the evening. But we would love to have you join for an informal, social, relaxing get together after a very, very intense filled day today. Tomorrow, got it, thank you. Tomorrow, we will be in the PAC all day. Neil mentioned we have 4 plenary sessions here. So the breakouts are today, we have 1 mock and then plenaries tomorrow, all here in the PAC. I did want to stress lunch today is provided by the Family Violence Center. And so thank you so much, Family Violence Center, for doing that. It's not a DPW provided lunch, but thank you so much. We really appreciate that. So with that, we're going to close. We'll wrap. Those of you attending the first mock, you are excused to go grab lunch, and then if you can let us know, we will let the rest of the people go. So thank you for all your attention this morning.
Oh, so like being Jesus.